And now over to Dr. Haimanti Choudhury, the beauty with brains from Assam.
Thank you. At the very outset, I'd like to thank Dr. Sudipta Mitra for making me part of this very interesting session. And I'll be talking on decoding multifocal for optimum patient satisfaction. I do not have any financial interest in this presentation. So is it multifocal? Is it really overrated, or do we really need it? So my answer would be yes, because presbyopia is a pain, and nowadays we are seeing more and more cataracts in younger patients, so we just cannot let them be with a clean distant vision. 60 is the new 40. You really cannot stop someone from doing whatever he or she wants if he is just above 60. So you have to give him both a great distance and near vision. And yes, our life has been invaded by devices, so we need a near vision nice. So patient profile, of course, I'll not go into the details. You have to discuss about the gender, the personality, the type of needs and requirements, the occupation, and of course the astigmatism part has to be dealt with. So contraindications, as my co-speaker has already said, I would say these are the relative contraindications, because yes, fussy personality you should not pick up such a patient who will be very cranky. And retinal diseases and glaucoma, actually you need to rule out. I would not say this is an absolute contraindication, because we do give multifocal and injections also. And night driving, of course, someone who is very much into night driving, you rather not give a multifocal. So one very important and pertinent thing that you should do is you should counsel your counselors on a regular basis, and you need to tell them that they should tell the patients that they will have a greater range of vision rather than spectacle independence. The mantra should be under promise and over deliver. So in the pre-op workup, of course, you do not want to miss out on a retina like this, so an OCT macula comes in handy. Dry eye has already been talked about. If you have one of these devices, nothing like it, but if you do not have, then Sherma and ocular staining will be good enough. For keratometry and biometry, let me tell you, when I started my toric practice, I only had this keratometer, and it is good enough. But of course, if you have a second device to validate your astigmatism, it is great. If you have the luxury of using an IL master, great. Otherwise, immersion can also be good enough for you. So which lens to put? Of course, you'll have to decide whether you want to target emetropia or the first myopia. And yes, I have a very low threshold for toric. As madam said, I would also put in toric for anything above 0.75. So some of the surgical step, one is you'll have to know your SIA. Then there has to be a perfectly sized rhexis, the middle video here, where I usually start and take the Purkinje image in the lens as the center of my rhexis, and then I'll take the guide of the pupillary border, which I'll try and keep my rhexis parallel to the pupillary border at all times, and the center would be the Purkinje image, and we target for 5 to 5.5 millimeter rhexis. And then the lens has to be a well-centered lens, and after you have centered the lens, and preferably the Purkinje image again should be in the center of the lens, then you need to have a complete visco wash, and it can be any brand of lens. There is nothing like, even our Indian products are doing extremely well now. So I would go and put in anything. There is nothing against Indian lens also. And then if you'd have done all these nicely, then there is ready, steady, and just shoot and go in and put a multifocal lens. And nothing can stop you from getting a result that you would like to have. Thank you very much for your kind attention.
Thank you, Haimanti, for your crisp presentation. And we have Dr. Praful with us as a panelist. Would you like to comment something on their presentation?
Sorry, I joined late, so I haven't gone through the whole PPT. Only one question from my side. Normally we have a tendency to center the lens depending on the Purkinje image at the end of the surgery. But in one of the discussion panel, the discussion was now the patient is lying supine, so it's fine. So what about the patient? Immediately the patient starts mobilizing when he is standing and walking around. So if gravity is going to decenter the lens, or is it going to like that where you have positioned at the end of this
As we have
procedure?
discussion about this toric lens, ma'am was saying usually the companies that we are using do not have so much of lens rotation or even gravity doesn't. If you have a shrink wrap, the IOL displacement usually doesn't occur.
Sir.
Yeah. So the question, probably the apicial need. The question was basically, why do you want to actually center it on table? Like, see, it's filling the bag. So what is the point? And thing is, it's really not going to really matter. So you're see. Yeah, absolutely. Yeah. I was just focusing on. Okay. Sorry. So if the first presentation was an excellent presentation, I think it showed dead bag syndrome. And this is the second, I have also seen one patient. So, and there's no, phimosis or, capsular axis edge, nothing. It is happening. And I have seen one patient. And we are going to see, without any predisposing factor, you suddenly find that the anterior capsular axis, the interior capsule is as fine as ever. There is no fibrotic concentric at the rim. So, and there is no predisposition. And suddenly, because of the inferior part, it gives way the inferior capsule, and you find that the IOL has subluxated or dislocated. So this is an entity which is coming up, and as and how we move around, we are going to see more of these dead bag syndrome. In my practice, what we do is that whenever a patient comes, he has a dense cataract. And if there is an exclamation or anything or asterisk, we make the patient party to it, so that the patient should take a decision. Why to put yourself under pressure? If the patient believes that he wants to go in for a multifocal so let it be his call. So, and I feel that despite our dissuading and telling the patients, those patients who are motivated, they still go ahead. But then your responsibility decreases a lot. One question which I would like the house to say, with patients with NPDR, do you go in for a
Ideally, no, sir.
Yeah,
but
that's
then
what I'm saying.
Ideally, no. But then
and if the patient
is
says he's ready,
persistent and
if the
is
patient
ready to accept,
yeah,
then. Sir, I would like to ask one.
absolutely, yeah. So this part has to be, we explain, and there are once in a while patients who do say, yes, we want independence. So let's move on with
So
it.
in that case, what type of IOL would you choose? Not a trifocal, definitely.
Yeah. We
So
can use the EDOF.
EDOF is better.
EDOF,
right.
EDOF IOLs can
EDOF
be.
are better.
Yeah,
So one question, because technology is advancing very fast. So I've experienced it myself. That's why I'm saying EDOF IOL patient, and then reads about something upgraded and comes up with no financial interest, with interest for synergy. So what would you do? Because I had a patient like this, and then after I did that synergy on insistence, after telling him that these are two different, the other eye he got dissatisfied. The second eye he was so satisfied. So the other eye, which he was having a bit myopic, I had to do it because of that. So now he had problems. Would you do something like that? Because I burned my fingers in it.
You mean in one?
It was EDOF
EDOF.
already, and then the
EDOF
next
means
generation
it was
came
Vivity
in.
type or
It was a symphony. Then only
Okay.
symphony was there.
Yeah.
So when later on this other one came on,
Yeah.
a synergy.
But
so
then you have to tell the patient that you
Yeah.
are doing, what I feel is, what we are trying to do is, we are taking the onus on ourselves.
Yes, yeah, that's right.
I think we have to move on.
Counsel
We have to
more.
tell the patient, we have to make him party to it.
Yes.
Once you make the patient party to it, then and it has to be a written consent in the patient's, handwriting that I'm getting this done at my own.
And there are people around, who would, I have seen surgeons around, they are not bothered about angle alpha, they are not bothered about scotopic, they are not bothered about anything. They are putting trifocals left, right, and center. The only thing which they are telling the patient is, it's a new device, it will take time to adjust. And more or less after 6 months, with the neuroadaptation, quite a few patients, they adjust. But we should not go that far. But with proper selection criteria, we should, and with active patient involvement. In our practice, what we have done is we have kept the same, it's a financial matter, we have kept the same margin for everything. So the counselors, they don't go out of the way. So that makes life easy for you.
Thank you, sir. Very well discussed. Our next topic would be, I'll just give you the mic. The next topic I would ask Dr. Chandni and Dr. Debojit to get ready. Yes, with IOL in tiny eyes. Yes, Siddhartha, please.
Actually, the patient is a CA, so he asked me an interesting question. Like, as I said, it's a spontaneous phenomenon. It can happen with anyone. He said, but you operated the other eye 3 months before this.
Yeah. Yes.
So how come this happened?
Yeah, yeah.
And the other eye is fine.
Yeah.
So I said, you should, because I always counsel the other eye can also have the same thing.
Yeah.
Right. So he said, how come your science doesn't explain that?
Yeah, absolutely.
He is happy otherwise. But then I also don't have an answer for that.
Yeah, absolutely.
No,
Absolutely.
similarly, when the patient in the someone in the family is very happy with multifocals,
Yeah.
so they want to come and get multifocal done, and then they keep complaining. So I think it's a lot of shared work that we have to do, and also the
Absolutely.
counselors.
Yeah, yeah.
That's the main.
It's a very interesting topic, so I'm very happy everybody is discussing. Anurag, 30 seconds, okay?
No, I just wanted to mention that since Dr. Siddharth had actually brought it to the sulcus, and somehow, I don't know how, but he got away with it. But the message, when we are calculating the power of a trifocal or a multifocal, the residual power should never be on the myopic side, and it should do nothing on the table to take it to the myopic side. If you're putting it in the sulcus, even with a proper anterior-capsular capture, it can still have a myopic residual. The moment the patient turns myopic post-operatively, the halos are going to be very magnified on the fovea, and the patient is going to be very, very unhappy post-operatively. That's just one message I wanted to give.
I discussed all this with the patient.
Yeah. Please come.